speak today about early breast cancer in the era of precision medicine, risk assessment and biomarker testing. I will tackle inshallah the hormonal treatment with trying to avoid chemotherapy, and Dr. Marian inshallah will go for other adjuvant lines of treatment. Introduction: breast cancer, as we know, is the second leading cause of cancer death in women, and approximately from breast cancer is 70% hormonal positive and HER2 negative. This is a Saudi incidence of cancer, and the breast is a leading one. And here for guideline recommendation of biomarkers for every breast cancer patient, we should do HER2 assessment, ER/BR assessment, also BRCA for special situations, and gene expression. As a baseline, there is factors to consider for risk assessment: clinical pathological for sure, this patient age, hormonal status, HER2, tumor size and grade, lymph node involvement, and the new, but it is not new, the gene expression 21 gene assay, and there is also 70 gene assay. This genomic assay for which this test will be predictive and prognostic. Prognostic assay, that means it will show us the natural course of the disease, how it will affect the patient prognostically. But for the predictive part of these tests, predictive part that can let the doctor decide which drug I can offer the patient, which drug can help the patient more. That's why they are accessing now multiple commercial available tests, but the main one and the only one that had predictive value is the Oncotype DX. How they invented, how they discovered this Oncotype DX affection to the patient prognosis and predictive to the doctor decision. There were many studies. First of them, NSABP B14, which showed the prognostic effect or value of Oncotype DX. Then they did this NSABP B20, and which showed the first predictive value of the Oncotype DX, and then Taylor-X study. For NSABP 20, it showed that patients with a high recurrence score more than or equal 31 have 28 absolute benefit from tamoxifen plus chemotherapy. That's why they wanted to refine this recurrence score and how to modulate the decision according to this recurrence score. In the NSABP P20 trial, they discovered that recurrence score from 0 to 10 has no benefit at all from chemotherapy, and from recurrence score 26 to 100, there is actual benefit for adding chemotherapy in the adjuvant setting. So they wanted to refine this recurrence score between 11 and 25. That's why they randomized those patients included in this trial, node negative as a cornerstone, and they randomized for endocrine and chemoendocrine 2 arms. And they found as a primary endpoint invasive disease-free survival. There was no difference between the endocrine and the chemoendocrine arms. Also, the second endpoint, distant recurrent free survival, overall survival, there was no difference between the two arms. That's why they concluded that from 0 to 25 recurrence score, there is no benefit for adding chemotherapy in node negative patients. We will subcategorize. And from 26 to 100, there is clear benefit from adding chemotherapy. In subgroup analysis, the age was the only factor that was found to correlate with the treatment response. That's why they categorize patient above 50 and below 50. Above 50, there is clear no benefit from chemotherapy from 0 to 25. Less than 50 or equal, there was a little benefit, but statistical significant benefit for these patients from 16 to 25. That's why NCCN included in its guidelines that the recurrence score in the premenopausal recurrence score from 16 to 25, this will benefit from adding chemotherapy to the hormonal therapy. In the postmenopause, as we mentioned, there was categorization below 26 and above 26. Also, ASCO guidelines included this oncotype DX in the node-negative patients, premenopausal and postmenopausal, and according to recurrence score, you can decide which treatment you will offer the patient. What about node-positive patients? There were no node-positive patients in the TILRX. Those patients were investigated by SWOG 8814 trial that showed that there is statistical significance, no benefit from the chemotherapy adding to the patient lymph node positive 1 to 3 if the recurrence score is between 18 to 30. Also, the two arms between endocrine and the chemoendocrine from 0 to 17 showed also no difference. The only difference showed from 31 to 100. Again, in the same sequence, they wanted to refine this recurrence score and how to decide accordingly. They initiated a responder trial, conducted, as mentioned here, to refine the chemotherapy benefit in HER2 negative, hormonal positive in N1 disease, lymph node 1 to 3. They randomized this recurrence score to two arms, endocrine and chemoendocrine. The primary endpoint was invasive disease-free survival, the secondary overall survival, distant disease-free survival, local disease-free interval, toxicity and quality of life. And here, invasive disease-free survival in postmenopausal, there was no difference between the two arms, and the premenopausal, it showed a difference between chemoendocrine and endocrine arm. Postmenopausal, invasive disease-free survival, no difference. Distant disease-free survival, no difference also. In the forest plot, all lines are crossing. There is no favoring to chemoendocrine arm or even endocrine arm. No favoring. In the premenopausal, there was a difference. That's why in the premenopausal with lymph node positive, there is no question. You will use chemotherapy. And there is no question for oncotype DX. Also in the forest plot, all the lines are in favoring the chemoendocrine side, except here, as we mentioned before, that above 50, the age matters. Above 50, the age matters. Okay, that's why the ASCO included in the postmenopausal, N0 and N1, you can use oncotype DX, and the premenopausal in N0, you can use oncotype DX as predictive for N1 premenopausal you can use oncotype as prognostic, not predictive. خلاص, okay. Also NCCN included as prognostic. All of these tests can be used: oncotype, mammoprint, PCI, endo predict. The only predictive test is the oncotype DX. So what should we give? Okay, hormonal, but which hormones? Firstly, the EBC-TCG trial, which investigated tamoxifen for 5 years versus placebo, because the tamoxifen was the first to be approved for benefit adjuvant hormonal positive breast cancer. It showed reduction in the risk of recurrence 50%, reduction in the risk of cancer mortality 28%, reduction of risk contralateral breast 47%. We will categorize our patient to premenopausal and postmenopausal. خلاص? First of all, oncotype DX, chemo or hormones. Get rid of chemo, hormones. Which type of patient? Premenopausal or postmenopausal? Premenopausal studies showed that premenopausal patients with ovarian ablation or suppression alone versus chemo CMF demonstrated similar anti-tumor effect. Chemotherapy CMF and hormonal with suppression, ovarian suppression, there was similar anti-tumor effect. That's why they conducted these two trials, famous soft and text trials. They were investigating tamoxifen alone or tamoxifen with ovarian suppression or exemestane AI aromatase inhibitor with ovarian suppression. These trials were randomized phase 3 trials, and this is a randomization here, and the patient criteria for soft and text also. 53% received chemotherapy before, 85% were HER2 negative, and 35% was node positive. Primary endpoint, disease-free survival, statistical significant for both ovarian suppression with tamoxifen and with AI. Subgroup analysis, which benefited more, who received the chemotherapy. Secondary endpoint, overall survival. There is overall survival with tamoxifen with ovarian suppression compared to tamoxifen. What about exemestane? It was non-statistical significant. Combine the analysis, and that's why they confirmed the result of those two trials. Disease-free survival, statistical significant for both ovarian suppression. Overall survival, not statistical significant compared to tamoxifen. Freedom from distant recurrence, statistical significant for both ovarian suppression with tamoxifen and with AI. That's why the recommendation is to give ovarian suppression, strong recommendation, to give ovarian suppression for patients less than 35. Chemo, also ASCO guidelines included, age, number of positive lymph nodes, tumor size, ARBR status, tumor grade, Ki67 to decide which patient to use ovarian function suppression. Also, NCCN guidelines recommends ovarian function suppression with AI for 5 years as adjuvant for higher risk patients of recurrence, young age, high grade tumor, lymph node involvement. So what about postmenopause? Aromatase inhibitors, several studies evaluated this. One of them is a TAC trial, which randomized the patient to anastrozole, tamoxifen, or combination. The disease-free survival showed statistical significant difference between anastrozole and tamoxifen. Also in the recurrence, it was statistical significant, but overall survival wasn't statistical significant. That's why in the attack trial, difference between anastrozole and tamoxifen, it showed reduction of the risk of recurrence, 26%, reduction in risk of breast cancer mortality, 13%, and reduction in the risk of contralateral breast, 52%. So combination wasn't recorded in this study. Combination showed no benefit at all, but added toxicity between anastrozole and tamoxifen. Is there any benefit for sequential? Combination is no benefit. What about sequential? For this big one, 98 trial was conducted. 4 arms, A, B, C, D. First arm tamoxifen, letrozole. Second arm letrozole. C, tamoxifen 2 years, followed by letrozole. D, letrozole 2 years, followed by 3 years tamoxifen. Primary endpoint, disease-free survival, showed favoring letrozole. And in this trial, with this favoring letrozole, they unblinded the trial. Because it was randomized, blinded, they unblinded the trial. They offered the patient to go to the second arm, which showed benefit with letrozole, and 25% of the patient shifted to the letrozole arm. Overall survival, there was favoring letrozole arm. And what about the sequential use? Why we are investigating and telling this data about sequential? Because sometimes we have shortage in one line. You can shift it to the second line and you will receive the same effect. No statistical significant difference between letrozole, tamoxifen followed by letrozole, or letrozole followed by tamoxifen. You can use those options. For how long you will use adjuvant treatment? Okay, to answer this question, there is 2 studies. Atlas study, which investigated tamoxifen for 10 years. What is the benefit of this? Recurrence rate for patients. It showed by 10 years, for tamoxifen for 10 years, 13% versus 14%. The recurrence. So the recurrence decreased by 1.5%. But the main thing was the carryover effect or carry-on effect. After stopping of tamoxifen, the patient continued to benefit from 10 years of tamoxifen. So that after 15 years, here, the recurrence for the 10 years was 21. And the recurrence for 5 years was 25, so 4% decrease in the recurrence risk. You got this? Again, after 15 years carry-on effect, the mortality from breast cancer decreased also by 3%. And also after 15 years, more than 10 years here, breast cancer recurrence decreased and the breast cancer mortality decreased. This is for tamoxifen 10 years. What about tamoxifen 5 years and AI 5 years? Here the MA trial, phase 3 randomized trial, tamoxifen 5 years followed by letrozole or placebo. The primary endpoint, disease-free survival. The secondary endpoint, overall survival, distant disease-free survival, safety and quality of life. Also in this trial, it was blinded, and the interim analysis after 2.5 years, the reduction in the risk of recurrence was 43%. That's why the investigator unblinded the trial for ethical issue. They told the patient that there is a high benefit from letrozole, and some of the patients were shifted to the letrozole arm, and disease-free survival showed statistical significant disease-free survival 94% versus 89%, and the secondary endpoint disease distant disease-free survival also was statistical significant here, and they linked between distant disease-free survival and overall survival. That's why in this arm they told there may be an overall survival benefit. For the duration, there is BCI, breast cancer index, also this gene assay, which can decide which patient you will stop after 5 years and which patient will continue for 10 years. If the score for this BCI is low, you can stop after 5 years. If the BCI is high, you can continue, or you should continue for 10 years. For this AIs, which AI you will use? NCCN panel confirmed that any AI can be used. Letrozole, anastrozole, or exemestane, all can cause or gain the same effect. After this data take-home message, the main thing we are following NCCN guidelines, you will differentiate premenopausal and postmenopausal. Postmenopausal, aromatase inhibitor for 5 years, accepted. Tamoxifen, she received 2 to 3 years, so please complete 5 years of aromatase inhibitor. Or 5 years added to the tamoxifen, so the total will be 7 to 8 years. Tamoxifen 2 to 3 years, and you have only tamoxifen. What you will do? Add tamoxifen for around 5 to 6 years. So the total 8 years of tamoxifen. Consider tamoxifen up to 10 years. Okay, no problem. In postmenopausal women, the use of tamoxifen for 5 years is category A, and up to 10 years. Okay, but it is limited to the patient who decline or who have contraindication to aromatase inhibitor or not available. What can we do? You will apply this approach. For premenopause, 5 years of tamoxifen, accepted. With or without ovarian suppression, also accepted. Or ovarian suppression plus aromatase inhibitor for 5 years, accepted also. After 5 years of initial endocrine therapy, what you will do? NCCN consider aromatase inhibitor for patient who developed postmenopause. She was premenopause. She received 5 years of hormones. She became postmenopause. Add 5 years of aromatase inhibitors. Based on data of Atlas, you can consider tamoxifen also for addition 5 years. For those who remain premenopause, you can use tamoxifen 5 years or consider tamoxifen 10 years. And as we mentioned, tamoxifen can be used to the lower risk patients, but the higher risk patients, according to soft and text trials, you should use ovarian suppression with tamoxifen or even better with AI. And that's all. Thanks for listening.